Once autonomy is understood as the moral right of individuals to govern their own lives and bodies, the question becomes how that right is respected in practice. In healthcare ethics, the primary mechanism through which autonomy is operationalized is informed consent. Informed consent is not merely a signature on a form, it is an ongoing ethical process that affirms the patient's status as a decision maker rather than a passive recipient of care. Historically, medicine functioned under a paternalistic model in which physicians made decisions on behalf of patients, often believing that professional expertise alone justified control. The rise of informed consent marks a moral shift away from this model. It represents a recognition that technical knowledge does not override personal values, and that ethical care requires patient participation. At its core, informed consent is the process by which a patient voluntarily authorizes a medical intervention after receiving and understanding relevant information. This process protects patients from coercion and deception, while also protecting clinicians from acting unilaterally in ways that violate patient dignity. For consent to be ethically valid, several conditions must be satisfied. First, adequate disclosure is required. Clinicians must provide information about the patient's diagnosis, the nature and purpose of the proposed intervention, the reasonably foreseeable risks and benefits, and available alternatives, including the option of no treatment. Disclosure must be tailored to the patient's level of understanding. Overwhelming patients with technical language can undermine, rather than enhance, autonomy. Second, comprehension is essential. Providing information alone is not sufficient if the patient does not understand it. Ethical consent requires reasonable assurance that the patient grasps the material facts and can appreciate how they apply to their own situation. This may require clarification, repetition, visual aids, or the involvement of interpreters. When comprehension is lacking, consent becomes procedural rather than meaningful. Third, consent must be voluntary. Decisions made under pressure, whether from clinicians, family members, institutions, or economic constraints, are ethically compromised. Voluntariness also includes freedom from subtle manipulation, such as framing information in ways that steer patients toward a preferred outcome. Respecting autonomy requires presenting options fairly, even when clinicians believe one option is clearly superior. Fourth, the patient must possess decision-making capacity. Capacity is task-specific and context-dependent, meaning that a patient may be capable of consenting to one intervention, but not another. Importantly, disagreement with medical advice does not indicate lack of capacity. Patients retain the right to make choices that others consider unwise, provided they meet the threshold for understanding and reasoning. Finally, informed consent requires authorization, an explicit or implicit indication that the patient agrees to proceed. This authorization should reflect the patient's own values and priorities, not merely compliance with professional recommendations. In clinical practice, informed consent is not a single moment, but a continuing dialogue. Treatment plans evolve, risks change, and new information emerges. Ethical care requires revisiting consent as circumstances shift, particularly in long-term treatment, research participation, or end-of-life care. When consent is treated as a one-time administrative task, its ethical purpose is lost. Informed consent also includes the right to refuse treatment. A patient's refusal carries the same moral weight as consent, even when clinicians believe the refusal will lead to harm. Respecting refusal can be ethically challenging, but it remains a cornerstone of autonomy. The role of the clinician is to ensure that refusal is informed and voluntary, not to override it simply because it conflicts with professional judgment. There are, however, recognized limits to informed consent. In emergencies where delay would result in serious harm and consent cannot be obtained, clinicians may act under the presumption of implied consent. Similarly, when patients lack capacity, surrogate decision makers may authorize care based on substituted judgment or best interest standards. These exceptions do not undermine autonomy. Rather, they reflect attempts to honor it under constrained conditions. Informed consent therefore stands at the intersection of autonomy, beneficence, and non-maleficence. It requires clinicians to balance respect for patient choice with professional responsibility to prevent harm. When practiced ethically, informed consent transforms healthcare from something done to patients into something done with them. As we move forward, informed consent will serve as a reference point for evaluating ethical failures in healthcare, whether through coercion, inadequate disclosure, or the erosion of patient voice. Understanding this process is essential for recognizing when autonomy is genuinely respected and when it is merely assumed.